Right now, all too common in the cardiovascular space, the application of diagnostic information is based on research at a population level. It's been very difficult to get to a personal level in cardiovascular care. We're all familiar with the very well sort of promoted ideas of personalized medicine, precision medicine, and cancer. And some of those ideas can transfer, but not all of them. It's very difficult to biopsy an atherosclerotic plaque. Of course, that creates the very problem that you're trying to solve, and so that's not something which is generally possible. Many people would like to use blood markers, serum blood draws, and various forms of analyses there. However, what's going on in the actual plaque tissues is where the story lies. And so it's not generally possible to have as specific or sensitive, or both, from a blood draw. So what we need to do is look at the plaque tissues themselves as if we had them in front of us ex vivo underneath a microscope. But to get that information from a non-invasive scan, and the purpose to which then that could be put is to move beyond population-based studies and to make specific decisions, particularly about the application of pharmacologic treatments, but at the acute form of the disease as well, to make the best possible decisions about whether to do a procedural intervention, what the type of that procedural intervention might be. But since the disease is not all the same, it's not capable of being done at only a population level. We need to be able to see the dominant molecular mechanism of the disease. We don't get there through spatial resolution alone. Spatial resolution matters, but by virtue of making inferences in the presentation of different tissue types, as long as they have been characterized objectively, different kinds of disease manifest differently. Some disease is driven, for example, by elevated blood lipid levels, and so agents that would drive those down below target might help that patient. But not all patient disease is driven by that. Systemic inflammatory insult might drive the disease in another group of patients. They wouldn't benefit by the intensive lipid lowering. In the converse, those patients that would benefit by intensive lipid lowering presumably would not wish to be given anti-inflammatories, which may affect inflammation elsewhere in the body, which is considered a positive. So the side effects may outweigh the beneficial aspect of the drug. So, of course, that's an oversimplification. There are multiple drug classes that go beyond those. Those happen to be current ones that matter a great deal right now. Many of the intensive lipid lowering therapies are very expensive. We can't afford to give them to everybody. So we need to know who will benefit from that treatment. And then we can go ahead and give them that treatment as a bargain, because they're going to benefit. They're not going to advance to acute events, but we're saving the money on those that wouldn't benefit and giving those people drugs that would address their condition. So the imaging technique that would be able to get to that level of specificity is where the innovation lies at Elucid.